Okay, so today I'm joined by a good friend of mine, Dr. Tom Chambers, who is the CEO. Sorry, let's you're not the CEO, are you?
Not the CEO,
Co-founder
co-founder
and
and
CMO.
chief medical officer. Yeah.
Okay, fine. Let's begin that again. So today I'm joined by a good friend of mine, Dr. Tom Chambers, who is an anaesthetist by background, as well as the CMO and co-founder of Theta Sleep. Tom, would you like to give us a bit of an intro to yourself? And yeah, it'd be great to just have a chat with you about your experiences and what you've been doing, and learn more about Theta.
Yeah, absolutely. Thanks very much for having me on. Lovely to see you as always. Yeah, so as you said, my background's in anaesthetics. I'm an anaesthetic doctor by clinical background, work in London, but I've been in and around sleep medicine for the past 5-6 years or so, which is this, at the moment, still far too niche specialty, but we need a lot more people working in sleep medicine. And unfortunately, there aren't great kind of training programs or exposure to sleep medicine, either in the clinical profession or generally in the public. But you kind of have to work your own way around it. So I've now done a master's in sleep medicine. I'm on the Royal Society of Medicine Sleep Council, and as of September last year, I'm also a somnologist, which is a rather grand sounding title for meaning sleep medicine. And yeah, so at Theta Sleep, we deliver a tech-enabled sleep medicine service. So what I mean by that is we have brought all of the innovations required to deliver a whole care pathway for sleep disorders, particularly a condition called sleep apnea, and deliver it entirely in patients' homes. So how do you take it fully out of hospital, deliver it all at home, make it nicer, more accessible, faster, all the great things that come with that. So yeah, we do that for both NHS and private patients, and all about trying to essentially just improve access, improve awareness, and manage sleep disorders better, really.
Amazing, great introduction. It's always fascinating to hear you say it rather than obviously just me fumble my words way through words like somnology, which I understand what it means, but I still didn't really understand the full scope of it. And I think that's because my understanding of sleep is pretty minimal for medical school, and yet it's something that's so fundamental to life, right? I was recently thinking it was such a silly investment to focus on beds and mattresses and stuff, but actually when you think about the proportion of life of one's life that you would hopefully spend in a bed to sleep, it's actually pretty significant. So why are we not really investing a little bit more in that, and understanding and educating ourselves about it, let alone our patients? So yeah, I'd love to just dig a little bit deeper. I mean, so I know you're an expert across sleep disorders. Maybe talk us through about some of the more common sleep disorders, and I guess why this is really topical right now and hitting BBC News last week.
Yeah, absolutely. It's great. There was 2 recent things on BBC News. There was a couple of weeks ago, we had Professor Colin Espy, an Oxford professor in sleep medicine, talking about a public health campaign on the 5 principles of sleep health, which is awesome. It's very much the place we need to start as a community, is kind of educating, understanding that sleep is this uniquely personal experience. This kind of one size fits all, you must get 8 hours sleep idea is very much in the bin in the sleep community these days. And that's where it all starts, is how do we prioritize it at a public health level before we get even into the kind of clinical side of sleep medicine. And it's fascinating because it does sit so in between the kind of wellness, well-being space and the clinical space. And there's a lot of gray area across the two, of course. And I think one of the big things around the campaigns, like, these 5 principles of sleep health is one of the things being prioritizing and valuing your sleep, and understanding considering if your sleep isn't right, if there's something, you're not feeling refreshed by your sleep, or your sleep is disrupted, or whatever that may be, and then considering whether you should go and see your doctor and get checked out for a possible sleep disorder. Now, yeah, you make a very good point on sleep disorders in general. It's not something we ever get at medical school. I reckon I must have had maybe 1 hour in the 6 years at medical school. Things are probably changing, but we definitely don't get enough. Broadly speaking, there are 6 different types of sleep disorder. Most of them are kind of fairly niche, but people know what they are and have heard of them. You get things like sleepwalking at a severe level sits in one of the categories. The big 2 are really insomnia and sleep apnea. Insomnia, I think more people have heard of, and more people are familiar with, more because it is something that if you have insomnia, you are aware that you are struggling with your sleep. This condition where you struggle to get to sleep or stay asleep, or you're waking up too early, and all of the knock-on effects that has. And I say it's more, people are more aware of it, and that is probably true. And I definitely get more people kind of out and about wanting to talk about insomnia, but it's still massively underdiagnosed and still massively undertreated. The best first-line therapy for insomnia is something called cognitive behavioral therapy for insomnia. It's not quite the same as sort of normal CBT. It's very focused on sleep health, sleep habits, how to treat insomnia in that way. And there's some great kind of digital therapeutics in that space too. But then what we focus a lot on, or what I see a lot of, is people with sleep apnea. And sleep apnea is this condition which is, becoming so much better appreciated, I think, and people are more aware of. As you said, it was in the BBC News recently. But on a surface level, it's a condition that affects, we think, probably more than 10 million people in the UK have sleep apnea. Wow. It's a huge number. And it is a condition where you are literally suffocating in your sleep, essentially. You are stopping breathing, sometimes hundreds of times over the course of the night. In severe cases, you're talking 50, 60, 70, 80 times an hour that people are stopping breathing or having shallow breathing. And as you can imagine, this really disrupts your sleep. Your oxygen levels go down, your heart rate spikes up, that fight or flight response kicks in. Your sleep is so disrupted, but often people don't know that their sleep is disrupted. You are waking up, but they're not really aware that they're waking up, and you can think you've had a normal night's sleep, and it's quite a hidden problem because of that. But the public health messaging that is improving on it means it's becoming a better publicized condition. People are coming forward to it, but that is obviously then putting on quite a big knock-on effect on the NHS sleep services, which are also kind of weren't set up to manage at the scale that we need them to manage at, essentially.
Yeah, totally. Thanks for pausing there, because I think there's so much in there to unpick, probably far more than we can get into the depths of here. But just, I guess, at a kind of really broad macro level. So insomnia, I think, to me, obviously, it's very, I think as a word, it's well used. Obstructive sleep apnea, so I always say, is slightly more nuanced medical terminology that I haven't heard lay people use. It's not the kind of thing I would expect to hear, in the supermarket or kind of people saying in offices, whereas insomnia seems to be getting thrown around left, right, and center. And I think that's because many people can relate with a sleepless night, which is not necessarily the same as probably getting diagnosed with, with a clinical grade in insomnia, and therefore needing a management of it. But then on the flip side, colloquially, people talk about sleep apnea as just being relating to snoring. So I'm keen to unpack some of the statistics a little bit deeper. I mean, let's just focus on the UK alone. You mentioned about up to 10 million people. I mean, that's a huge, essentially one in 5, 1 in 6 of the population. To dig deep a little bit in terms of who does this affect really, and how can one really identify whether they have it? Is it only through formal sleep studies?
Yeah, so I think in terms of who has it, there is a massive, it's not just a public misperception, it's a professional misperception. There is this misconception that sleep apnea is a condition that affects people that we picture snore a lot, which is traditionally your older, overweight, middle-aged man, which is, there's a fair bit of stigma attached to that as itself, which makes that damaging. But the other important side of things is it can affect anyone of any age, of male, female, obese, non-obese, slim people, anyone can get sleep apnea. And the variety of symptoms that sleep apnea can present with is really, really broad. The traditional symptoms are exactly as you say. You get very loud snoring, and that is often what makes people present, because it's often a bed partner who says, you're snoring terribly, I need you to go and see your doctor about this. And that kind of really gets to the point that it is often a kind of bit of a hidden problem if you don't share a bed with someone, or they're not concerned. That's why people can be missed for such a long period of time. But it's not just snoring. The traditionally it's sleepiness is the main symptom, which can be hard to appreciate. I've spoken to many patients who have sat with very severe sleep apnea for 20 odd years or so, who stopping breathing hundreds of times per hour, they feel groggy in the day, but they've kind of always felt that way. So they have never really thought, I wonder if this is some clinical disorder that I've never heard of before. And then you find that when you identify it and you treat it, that it's the number of people who describe it as life-changing is amazing. Like you do hear that, and that is because, as you say, sleep is something we spend a third of our lives doing. It is, nature's best tonic. Some people describe it as, it is a wonderful thing to sleep well and sleep properly and go through all those wonderful kind of restorative elements of sleep. But yeah, it can affect anyone. The other than sleepiness, it can present in subtle ways as well. Fatigue, brain fog, morning headaches, dry mouth, nasal congestion. The symptoms can be really quite subtle, and they can, particularly in women, can be more subtle. You can get more things like insomnia symptoms where you're getting more broken sleep. You can get that brain fog, the mood swings, etc. And you've just got to have a really low threshold to consider it, essentially, and go and get checked out and get diagnosed. So the way we do diagnose it, to your question of how do we identify it, it is through a formal study called a sleep study, and there's loads of different ways you can do that. But the first kind of, from a public health perspective, it's think whether it could be this, get to see your GP and get that referral to try and get checked out for it. And that's when you get into the sleep study that you can have. And then there's 5-10 different types of sleep study that someone might have, and lots of really exciting stuff happening in the space at the moment. Much more lightweight, more accessible, can go through the letterbox, some of them that you can pick up. Back in the day, you were in a laboratory, wired up like Frankenstein, bands everywhere. It was really quite an unpleasant experience, and things are a lot more lightweight for certain people who, you can use different studies on different people depending on how someone presents and what else is going on.
I think that's exactly where you sit, isn't it? At that juncture of being able to deliver sleep services at someone's home, which is kind of the new era of medicine that we are sort of finally getting to, which I think must be for your world game changing, because I've spent a bit of time over the years looking at some of these technologies, especially with the wearable devices you mentioned, where people can do it at home, and kind of looking at pictures of the old school studies, which I'm sure people still do in sleep labs, and thinking, I don't necessarily feel like I have issues with getting to sleep, but I imagine if I'm wired up with that in an unusual place for one night, I probably would. So I wonder how much of a confounding variable that is. Is that something you've noticed for someone who's probably reviewed hundreds of these over the years as part of your training? Is that something that you notice when people come into a sleep lab? That first hour or two is largely noise?
Well, it's not even necessarily the first hour, but sometimes, the whole night can be a disrupted night's sleep. And it's not just, there is this phenomenon in research or clinical stuff that's done in sleep laboratories. There's something called the first night effect, or if you bring someone into an unfamiliar environment, you sleep like crap. Of course you do. It's new. Your brain is, there's really interesting things going on in your brain. You're on a heightened state of alertness. It's not just in a sleep lab. If you do this, if you go to an Airbnb or a hotel or whatever, you will get the same thing. You won't sleep as well. You've got a slightly different kind of sleep architecture on that night. And that is where some of the wearables can be great. There is a promise, certainly, with some of the more clinical grade wearables, because there aren't that many out there in the sleep tracking space at the moment. But they can provide a longitudinal assessment of someone in their home environment. So every single night you can look at someone's sleep. And that's definitely the way we need to go, because we know not only an unfamiliar environment, you don't sleep well, or you're wired up, you don't sleep well, but sleep changes every night. It's a dynamic process, and your potential sleep apnea changes every night. The severity can fluctuate quite a lot on a night-to-night basis. So although we still do rely generally on a single night sleep study for individuals, it can be, you can get a false negative in that case. And that's when it's really, really important to have the clinical consultation with someone and understand their sleep and discuss their sleep and understand what their symptoms are like, and whether there is a chance that single night that you've got the data for is potentially not representative of what this person's life is usually like. And just, it's a complex and really interesting area that you need to have that conversation, that consultation with someone once you've got the sleep study. You never just treat numbers in medicine, do we? But it's one of those things where you've really got to understand, what else is going on. If they are coming with symptoms of tiredness, fatigue, etc., and the sleep study is negative, is it because we need to do another one, or is there something else going on here that we should be thinking about?
Absolutely. I think you and I both know and will agree that these end-to-end services are really key to that. I think building regulated services run by experts and professionals like yourself that do the full pathway, from inquiry to actually converting that into a formal consultation, capturing all the relevant data and information, and then being able to deliver appropriately safe diagnostics, make a diagnosis with a consultation, considering all that nuance, and then making a management plan with the patient. I think that's, and typically, I'm probably summarizing from other conversations we've had here, but typically this pathway, if one was to go about it in the NHS, is quite lengthy, isn't it? It's probably a few years if you can even get to getting the diagnosis and the diagnostic in the first place. Is that correct?
Yeah, it can be. And it's one of, I know we always speak about postcode lotteries in the NHS, but this one does really upset me, because there are not enough sleep centres in the country. We know that the sleep centres are not in the places of greatest geographical need, and we know that sleep disorders disproportionately affect individuals from more deprived backgrounds, but the sleep services are not there. And when people have to go in and out of hospital for their sleep medicine care, traditionally to go and pick up this kit, if not to do it in the hospital, there's so many people who can't get there because it's hundreds of miles away. They don't have a local service, particularly in rural parts of the country. And it's why it's something that then, from the kind of optimistic and positive side of things, sleep is wonderful because you can do it at home. The infrastructure exists quite uniquely for sleep medicine care to do it in someone's home, in contrast to other conditions that might need chest x-rays or CT scans or some other investigation that you do need to be in a hospital for. And it can be done at home and should be done at home. And that is where, it's where I would rather have my sleep medicine care. Certainly, I'd rather everything else was delivered to me. And I think the ability to kind of improve accessibility there, reach more people, and deliver the care faster and better and at a lower cost is what makes it a really exciting place to be working in.
Amazing. So I think one thing that would be really great to understand and hear more on. I have obviously an understanding from my clinical background, but it'd be great to hear from maybe listeners who don't necessarily appreciate how serious this could be. What are the dangers of remaining undiagnosed with OSA? So I can imagine people just saying, well, I snore, but it doesn't affect me, affects my partner. And I'm none the wiser because I wake up maybe a bit groggy, but I've been groggy for 35 years. Why bother?
Yeah, so it's a great question. I think even that first one you're saying, if it bothers your partner, there's all sorts of very interesting stuff around, sleep problems and the knock-on impact they have on partners. And that in itself is a really important thing. If you're disrupting your bed partner's sleep, you're disrupting their life and their quality of life and their well-being, etc. So that in itself is a really good reason to get yourself checked out. But on a personal level, there's the daily impact. We know it significantly reduces people's quality of life, your energy levels, your mood, your general sense of well-being with sleep apnea and other sleep disorders is reduced. And if you treat it effectively, those things improve. We see that in patients the whole time. We see those energy levels go up. You mentioned that BBC News article the other day. There was a great story in there about someone who was overweight. They got their sleep apnea diagnosis. They started on CPAP originally, which is our main treatment for sleep apnea, CPAP, which stands for continuous positive airways pressure, which is a little machine that goes by the bedside and gently blows air in to keep your airways nice and open, because them closing off during sleep is what's happening with sleep apnea. But this person who then went on treatment and kind of understood what the problem was, and she got treated, energy levels increased, she was able to get out more, she was able to, eat healthily, exercise more, lose weight. And now I think the story was saying that she's now off the treatment that she was on beforehand. And I think you do hear that story from time to time, in that it does, it's not just sleep apnea, but it's then just prioritizing your sleep health and the impact that has on your appetite, on your kind of emotional regulation, on your hunger, etc., that can make a massive difference. But then in the kind of more serious end of the spectrum, as I said, this is a condition where you're stopping breathing multiple times, your oxygen levels are going down multiple times, your heart rate's spiking up multiple times. And that does increase the risk of really serious problems like heart attacks, like strokes. Increasingly, we know that it's linked to dementia and Parkinson's disease. And ultimately, an early death from it is what we see in the data. And it is, therefore such an important thing to go and get checked out if you think it could be an issue, because we do have effective treatments for it. And it is something that, people do get massive benefits from when they identify it and know what's going on and can work out the way to manage it.
Yeah, I think that's a really important message there. And I think you're really only scratching the surface, because even from my knowledge, and again, not an expert to any degree, I'm thinking more about just kind of general disruption to your circadian rhythm and all the kind of knock-on sequelae with other general gatekeepers of your health. So I think lots of things can be attributed to some level of disruption and imbalance in hormones, and then, as you say, knock-on effects which might manifest in cardiovascular system or whatever that might be. So I think there's probably a much greater degree of other comorbidities, which themselves might actually be the first thing to be diagnosed. So quite commonly, I think, with diabetes and people with a more metabolic type picture, that gets identified much easier on an over 40 check, and they get put onto a management plan for that. But it's very possible that they actually may have had OSA for many years. That was actually a significant contributing cause of it. Whether it's the full story is not necessarily, it's probably much harder to prove. What's your kind of view on actually the much bigger implications that OSA could signal as a contributory cause for all cause morbidity and mortality?
Yeah, absolutely. I think it's one of the areas where, again, I think things are getting a bit better of appreciating what some of these kind of indicator conditions might be. High blood pressure is a real classic. There are patients who have been on 3, 4, 5 different blood pressure medications for years, and they've never had their sleep apnea diagnosed and treated, which can then resolve it. Irregular heart rhythms, atrial fibrillation being the common one, is often resistant to treatment until you identify and treat the sleep apnea. Diabetes, as you mentioned. There are other things that I think are less well known. We're talking kind of in the men's health space. Things like erectile dysfunction can be caused by sleep apnea. We've had patients over the years who have had erectile dysfunction that is driven by sleep apnea, because it is causing this, as well as the big vessel problems, it's causing the small vessel problems because your oxygen levels are going down. there are so many things it's linked to and so many opportunities to screen for it in those cases, to then identify whether it's a driving characteristic. Because as you say, it can be something that ticks along undiagnosed for years and is actually the root cause of so much of this. You see it also quite a lot, in the menopause, for example. Sleep apnea is a condition that does affect men more often, but we're very bad at identifying it and trying to diagnose it in women. It's something that we need to be a lot better as, is a specialty. But often in the menopause, you'll find that people have, tiredness, fatigue, difficulty sleeping that can go misdiagnosed. And people will go on hormone replacement therapy and they won't feel any better. And actually, it's an underlying sleep apnea there, because the risk of sleep apnea goes up significantly after the menopause. That the prevalence in men and women after the menopause is about the same. That risk category changes at that point. And again, it's just so many opportunities that we should be prioritizing our sleep health and whether there is a sleep disorder going on there as well, because it is one of the single best things we can do to improve our health and well-being.
Yeah. I mean, very simply, there's huge ramifications for broader public health if we could get this right. So if we could obviously diagnose, maybe not necessarily prevent, that's a separate issue, but at least diagnose and manage accordingly and early enough over time, then I think it's going to have significant benefits, not only at an individual patient level, but at a population level as well. So I think the opportunity is huge. I wanted to sort of, I guess, dig deeper a little bit on somewhere we probably have shared ground. You mentioned erectile dysfunction, and that's obviously something that I spend a bit of focus on with my role at TED's Health, and our kind of focus being men's health, and in a similar manner, having an end-to-end solution that is digitally enabled. And it's very interesting as well you say that, because I think there is a perception, and it might be a slightly controversial take, that clinicians and others who work in the more traditional healthcare service will see ED medications being sold online. And, we now know there are OTC versions available from pharmacies as well. And, it's a topic of taboo still. Unfortunately, lots of things are still very stigmatized, including menopause, sadly, and hormonal health as well. And yet, and people will just see that as being, well, there are companies out there, including online providers, who are just doing it from a means to profit, and really to kind of tapping into the fact that it's because it's taboo and people don't want to go and speak to a GP about it. Well, they're just trying to make a quick buck there, but actually missing the broader second order kind of implications on the public health level, that actually typically, but not always, erectile dysfunction could be a real herald of cardiovascular disease, the ticking time bomb. It's in fact been shown to be an early indicator of cardiovascular disease. Sorry, one of my kids has come running in. I just re-divert them. All good. So I think erectile dysfunction is just one example, and of course we focus also at TEDS on the hormonal aspect and looking at low testosterone, hypogonadism, the diagnosis of that, and then where appropriate, prescribing replacement therapy. I'm interested because it's something I've only been kind of reading and digging more into the potential impact from sleep being a cause for low testosterone. I'm curious from your experience, what you have seen, and have you seen it to be something that patients are commonly coming to you with, or is it more a case that actually there are lots of other undiagnosed things that finally, once they end up on a sleep pathway, they start actually going through and starting to resolve?
Yeah, I think it's a great question. I think one that almost I'm going to kind of have questions back for you on this, because I think, I spend my life telling people how sleep disorders are not in the public domain enough, and we don't know enough professionally about it. But certainly I think from that hormonal health perspective, as you mentioned, and obviously as a focus of what you do at TEDS, is, that's an area that I don't think know enough about, and get taught enough about, and are educated enough about. I was chatting to yourself and other people recently, and looking through some of the guidelines on testosterone deficiency and hypogonadism, and the indications for when you should, potentially consider whether there is a testosterone deficiency. And I feel like that's not the kind of thing that we're aware of. Again, certain age groups, metabolic profile, sleep disorders, diabetes, etc. I feel like it's the kind of thing that we don't look at enough. And you often, in sleep clinic, we'll often have patients who have had a set of blood tests from their GP, as we would call in the medical profession, the tired all the time blood tests, which, cover all sorts of endocrine problems and thyroid and diabetes, etc. But I don't often think there's much hormonal health in there. So I'd be interested to know kind of your take on that, as to, what's your experience as a GP in that space, and in there, as to what the awareness is, and how often it gets picked up. Because I don't think, I don't see it spoken about enough, I guess, is the honest answer. In the sleep space, it's certainly an area that I'm always keen to learn more about, for sure.
Yeah, no, thanks for adding that on the TAT profile, as I call it, tired all the time. I think you're absolutely.
I'm certainly going to advocate on the TAT profile, as I speak to a few GPs. If you're doing tired all the time blood, you should also be looking for sleep apnea, I think, because
and possibly and more hormonal disruption as well for men. Possibly testosterone is something to consider. It's very nuanced, and I think it's being selective. But you're quite right; these are not commonly included in these panels. So, and I think there's, without trying to reiterate a lot of what you've already said so far, there's minimal good education at medical school level. It comes under the remit of endocrinology, but endocrinology is huge, and there's so many different hormones, and we learn about the axes and circadian rhythm, and the kind of, it's very fun kind of drawing all these different axes and diagrams and kind of saying, okay, this is all centrally regulated, and if it's not, trying to identify at which level disruption occurs, which is all very, very important then when you get into wanting to understand this more, diagnose it, and then hopefully be able to treat it. I think these are all critical things that typically would happen only at specialist level, so secondary care level, tertiary care level, which then brings us to the next point, that just very much like sleep disorders are poorly understood even in a clinician community, it's the same for hormonal health. I would argue, obviously, you would probably struggle to find a clinician who is not aware of the menopause and the HRT, and at least what that entails. Not necessarily know the diagnostic criteria, though. I think that's, again, something that I didn't leave medical school not necessarily knowing it particularly well, or being comfortable at being able to manage that. And again, it's not something even most doctors in training have too much exposure to, at least back when, when I started working 10 years back. It's and I think it is now changing, but men's hormonal health is a different kettle of fish. I mean, without digging deeper too much into that, otherwise that's a whole other essay and topic, but there's a lot of stigma, unfortunately. I think some of that stigma is cultural. The understanding and awareness of men and how we behave with healthcare systems, how we engage or disengage, again, is still poorly done, and we haven't adapted the service for the needs of most men. Men in society historically have often been a patriarchal type figure, which is one that is quite stoic and one that does not complain. Certainly in the UK, kind of a British culture of having a stiff upper lip, not wanting to be seen to be complaining about any health issues. And I think, again, you and I will probably commonly agree that even in our NHS practice, we'll have seen a patient who's come in, a man in their middle age, who would basically tell them they've got no medical history, but actually you'll find that they are diabetic, they've got high cholesterol, they should have been on lots of treatments. That's because they're not really engaged, and or they've come in and they've had chest pain for a very long time, and actually it's just been, you know, essentially unmanaged, and because they've not wanted to engage with clinicians and undergo a consultation and diagnostics. So I think it's trying to understand how we can meet our target demographic in the middle, and that's again something that we're very passionate to try and do, and that is again trying to find the solution to how can we make care more accessible, and digitally enabled allows us to do elements of this at home or in a more convenient fashion. So, you know, potentially having an at-home blood test. Again, we advocate for doing venous phlebotomy where possible, but you know, we have also adaptive models to try and incorporate kind of more affordable and accessible means for blood tests and other devices as well. Bloods are a very fundamental part of identifying hormonal regulation. I think it would be silly to assume that you could make a diagnosis without it. I mean, there are certainly clinical symptoms, but again, just like using the example of insomnia, although it's maybe not the best example, I think we have to be very careful with what patients and people say. Semantically, you could say, yes, I feel tired, but that could be any number of underlying medical conditions. It could be multiple of them at the same time, or it could be none, because it could just be simply subjective opinion, or, you know, a sort of state of mind. So while the symptoms are far-reaching of having low testosterone, very much like I'm sure having a sleep disorder, there are obviously kind of key ones that clinicians hone into. Very simply, though, just to cover some bases, I think key things we look at, I like to break it down across kind of systems. Typically, the ones that people probably know but they don't want to talk about are kind of sexual related side effects. So low or loss of libido, a loss of interest in sex and sexual activity. Erectile dysfunction often ties in with that, and typically that can be found when total testosterones drop below a certain level. So it can actually be a cause of erectile dysfunction. It's not the only cause, as we've learned today. So, sleep apnea could be a cause. Cardiovascular disease could be a cause. Perspective, which again, all of these things are associated with increasing age. Diabetes as well, kind of glycation, stiffer vasculature could obviously affect you know, erectile health. And then of course we must not forget the elephant in the room, which is the psychological component as well. So I think the sexual side effects probably don't get enough airtime, if I'm being honest. People often try and say it the other way around, but actually I think these are key things, because again, I find when finally I get to speak to patients, that's the thing they bring up the last. They'll say, well, I'm feeling tired.
It's probably the most important one that they wanted to mention. But
and most of the time, well, I'm tired, and now I've done the blood test and the blood test is showing I'm low. Okay, what's next? And it's like, well, hang on, let's build up the full narrative. And it's really important to delineate, again, systems level thinking, kind of what might be impacting end organs versus just kind of how you subjectively feel. But mentally, yes, I think there is two sides to the mental side of things. There's obviously the cognitive aspect, so that might manifest as kind of poor attention span or concentration, brain fog, can potentially affect memory. Things I imagine also would resonate with poor or lack of sleep as well. And then, of course, from a mental health perspective, it can certainly impact one's mood. And again, I think that goes hand in hand. If you're feeling tired and fatigued and are struggling perhaps with your day-to-day activities, which might impact your work, that probably will have a knock-on impact on mood. So I think it's very important when I say mental health to not ensure that we are kind of trying to label other kind of mental health conditions and talking that down to low testosterone or hormonal disruption.
Mm-hmm.
I think all of these things also need to be looked at individually as well. And it's very common that you could have concomitant, so that means more than one medical condition at the same time, as I'm sure you see a lot in your world with sleep disorders as well.
Yeah, absolutely. For sure, we see that the whole time. People often talk about sleep disorders as London buses being, always coming as a pair, and that is true. They are so comorbid. Someone with insomnia often has sleep apnea, and the same is true the other way around. You were mentioning about the blood tests that you're doing for looking at hormonal health and the various different approaches for it. That is then, and you're talking about how you're then discussing those in clinic with patients. Is that itself quite a complex area to understand what the various, because there's no kind of, it's not like other blood tests, right, where there's really hard and fast, clear and obvious cutoffs and like clear, this is what you must do next type thing. Is it one of these things that's quite nuanced? How do you manage that?
I think there is nuance to it. I think there is definitely confusion and maybe disagreement in the medical community globally. There are certainly physicians I've spoken to in the US who kind of advocate for, well, less importance or relevance of blood tests and kind of saying, well, it's all a spectrum. And while that's not necessarily wrong, I think it is very important to have biomarkers underpinning a diagnosis. I mean, I think you and I will agree that lots of things might seem like a spectrum, but I mean, we could use diabetes as an example as well, and kind of HbA1c levels, and again, where maybe at a global level, WHO would set a level, and how that's changed over time, and how we've even shifted to using better markers like HbA1c, so which is kind of essentially looking at the impact on blood cells, glycation of red blood cells over a good period of time, 3 months, rather than isolated episodic blood sugar levels one-off, which is impacted by so many variables on a minute by minute, day-to-day basis. So in the same way, we follow the British Society of Sexual Medicine, the BSSM guidelines, which advocate for 2 separate blood tests, at least 4 weeks apart, between 4 and 6 weeks apart. And that is partly to try and build up a better longitudinal picture than one siloed sample. Just like diabetes, there is also variability based on time of day. So a bit of diurnal impact. Why? Because we know that typically testosterone production and release into the bloodstream is highest in the early hours. And if one is having good quality regular sleep, then you would imagine that this is optimal. But if it's not, i.e. they are jet lagged, which happens with people who travel a lot, maybe not everyone is that lucky, but sometimes with work people are doing that. So the next ones are shift workers. So you and I have both sets of shifts and nights and have still been doing kind of lots of late. So my sleep is very disrupted. But even if you don't fall into those categories, lots of people are possibly young parents, woken up, and you have disrupted sleep, and therefore that does have an impact on your kind of hormonal health. So the timing of doing a blood test is important, but I think the context of that person's day or week or schedule and what they do for a living has to be also taken into account when interpreting this. We do find, though, however, that diurnal variation is less relevant in the sort of mid to late 30s onwards. It's very noticeable if you look at blood work of teenagers or men in their 20s, and I suspect, given the kind of huge surge in the sex hormones, including testosterone, in both men and women, but specifically in males, during puberty, being a huge driver of all the change that happens and the growth that happens there, that obviously stands to reason. So why do we look at all of this, and what's the relevance of testosterone and low testosterone? Well, very simply, having mentioned just puberty and growth, after that settles, one is in their adulthood, levels unfortunately don't stay the same all the time. They're not consistently raised. They do start to decline. And I think this is, again, an area for great discussion and awareness. Again, with menopause, most people understand that this is in a certain time frame, but it is, again, across a few years, and it's more a noticeable shift when women reach a certain age. However, andropause is a term that's used that I don't particularly like, because it almost draws too many similarities and parallels which is not, scientifically accurate or true. So I don't really love that term, but it is something that's around in the press, and people do. So for men's health and the male sex hormones, testosterone starts to decline on average somewhere between 0.5 to 2%. Again, that's quite a range, but so we could say 1% on average. But again, there's personal factors here, from your mid-30s onwards a year. So over time, I think when people would get to a similar age that maybe women may be experiencing menopause, that particular man's testosterone levels may have dropped, potentially up to 10%, 15% from where they had previously been. And that is assuming that their baseline levels have consistently obviously stayed in an optimal range. And of course, again, there are numerous disruptors. We've spoken about circadian disruption, and I think that's a key, because I keep coming back to sleep being so critical to general health, for all the reasons you said. It's so vital for rejuvenation of our systems. And I think no less true in the kind of hormonal health and testosterone. But very simply, as a result, with disruption from either kind of inherent biological causes, or whether it's external factors, the environment, things that we put into our body, whether that is kind of nutrition or lack of, whether that is the stressors that are affecting us, which probably have an impact on cortisol levels. Rising stress hormones, cortisol, typically will account for kind of lowering testosterone. It's almost a yin and yang like effect. And so when someone is chronically stressed over a period of time, whether that's psychological, whether that's physical, mental, and usually they start to come across and affect a more broader picture, then that's going to disrupt many things. Not only testosterone as well, that will probably also be seen in blood sugar control, blood pressure, and other systems as well, as we've sort of covered. So these are only scratching the surface on things that can disrupt the hormones. But I think it's fascinating to start on lifting the lid, and as I've just covered only some of it here, but you probably start seeing, well, actually there's so much there to unpick. It's something that we probably take for granted, unfortunately. But sadly, it's something we just still don't talk enough about.
Yeah, absolutely. There's so much in everything you're going through and describing there. There's so many parallels, I think, in the worlds that we're in, of just thinking about general health and well-being and the things that can be causing that kind of mixture of symptoms, be it sleep, be it mood, be it hormonal health, be it other medical conditions. It's there are so many parallels to what I see the whole time with that as well. I mean, imagine, as you're saying, about the things that are causing sleep disruption and reducing your production of testosterone, etc. And that, again, it's probably something that is so underappreciated because we don't diagnose enough people. But I can't imagine the number of people with hormonal health, a number of men with hormonal health issues who are being driven by potentially undiagnosed sleep apnea and not allowing them to get into that deep restorative sleep where we are producing these hormones. Because we think that probably 85% of people with sleep apnea are currently undiagnosed, and some studies suggest it's higher. It's one of those things that, as you say, as you're saying, scratching the surface. It's once you start scratching the surface, you will see it everywhere, and knowing how best to manage that, I still at scale, I think is something that we as a community are still trying to work out, really.
Yeah, totally. I think if there's one thing I'd add, it's people would often, I think critics or cynics here will say, well, these sound like problems now that companies are trying to take advantage of and kind of capture, essentially providing solutions to things that now we only know about now, but society's been functioning very well without. And I think, again, we'll probably agree that there's been issues with diagnostic criteria and availability to even and access to even be able to diagnose people properly, and that's why we're only really now understanding the scale of this. It's not like it's, again, it had a very interesting conversation with someone about neurodiversity and ADHD, and again the kind of seeming increased prevalence there. I'm sure there are tons of other modern day society factors, social media, and in those cases maybe attributing to that, and I think, but I think we can't also get around the fact that now that we know these things and we are actually better at being able to delineate and unpick things and diagnose things properly, I think we have a right to do that, to be able to treat patients better, rather than just assuming that we can treat things very simply. I mean, you probably have seen this in a sleep setting, but I've seen it many times that unfortunately men go to their GP saying they're tired, try a few things, or maybe have a TAP profile which comes normal, and then the next thing they're offered is antidepressants. And their mood may be a part of it, and in some cases I'm sure perhaps is the story there, but it's not always the case. And I have seen cases which have stopped the medication or never started the medication, later then gone on to find out that they had low testosterone, so formally diagnosed with hypogonadism, went through a pathway of diagnosis, and some of whom came through to us at Ted's Health and started treatment to correct that, so replacement TRT, and they normalized their testosterone levels, which improved many things, including their mood. So seemingly corrected the one thing that they essentially had been wrongly or misdiagnosed for. So I think that's one interesting thing. And I mean, another thing I was going to say is, I wonder how much of this is also partly due to the society that we live in. It's very fast paced. There's a lot happening in the world now. There's a lot of things to keep people up at night. If you read the news or watch the news, there's a lot of exciting things as well, especially in the kind of tech space, especially with AI. I guess maybe a sort of final question, as much as I love this discussion, but go on and on, to you would be, well, what do you see is the future of sleep medicine? Where do you see sleep medicine going? Maybe where Theta is going to move and take advantage of, but where do you see this evolving over the next 5 to 10 years?
Yeah, so I think it's a great question that you can answer in so many different ways. I think in the sort of short to medium term, and this is very much where we are focused on with Theta, is how is actually practically delivering that sleep medicine care out of hospitals and in patients' homes. Anyone who's familiar with all of the content in the NHS 10-year health plan and the big push from the government of how do you do things in the community, digital first, preventative healthcare. And I think sleep medicine has a real chance to be that poster child of it. It is, as I said at the beginning, one of the fastest growing, it's the fastest growing diagnostic test that we do in NHS. And it is a real problem. And there is a very real fix to that, of delivering the care in patients' homes and then managing at scale and giving everyone a really high quality of clinical sleep medicine care that we can do, that we know exists. That's probably I'd like to see short-term future. I think the reality of all these things is things do move slowly in healthcare, and it will be more like the medium-term future. Longer term, I think there is going to be a phenomenal amount of work, and hopefully really meaningful work, in understanding sleep and longitudinal measurements of sleep better. all of the wearable data that is coming out will eventually be very, very, very good. I think at the moment, I don't think we leverage wearables very well. It's, again, talking things I'd love to talk about in great detail another time. Largely what wearables currently do and how they're currently used doesn't help sleep health at scale at all. But the data that's coming off them from a cardiovascular health perspective, from a sleep variation perspective, is amazing, and I think will make massive changes. And only a couple of weeks ago there was an amazing paper published looking at using, this is in laboratory studies, but using data from a night's sleep in the laboratory, single night, and how it can predict many different diseases going forward. Sleep as that real kind of window into the rest of our health is kind of more long-term, potentially the sort of futuristic era of sleep medicine. But I think there is so much to be done in the shorter to medium term that we can deliver on meaningfully. It's just, we just need a bit more desire, I guess, politically, and a bit more movement for the right commissioning and the right delivery of care within primary care. And that can happen at the moment. That is why we're doing what we're doing. That's why we've built the infrastructure that we've built. That's why we've built our digital platform to manage it, and our pathways and our workforce to actually fulfill that now. And hopefully I'd love to see that is where we begin to just see sleep medicine care delivered, and it makes it so much more accessible for the millions of people currently suffering from undiagnosed or poorly managed sleep disorders.
Totally. Yeah. Amazing. I think if I was to maybe end on my views, I think from my perspective with men's hormonal health, I think my kind of one takeaway is just actually the key thing here would be just raising awareness and education. So I think the right type of awareness. I think it certainly helps to start with providers and clinicians. I think breaking some of that stigma, the former associations with kind of underground labs and anabolic steroids and people gaining things and self-medicating, but actually approaching it in a more nuanced way and exploring where there are symptoms and someone is of that potential age. The age bracket is actually much larger than people think. It's not a condition of old age. Actually, it can affect people, young adults too. And yes, say sort of mid-30s onward, but some people younger are affected because of multiple disruptors and other factors. And really exploring that, again, there is such clear interplay and connections with things like type 2 diabetes and the kind of more metabolic picture, and I'm sure also sleep as well. So being a little bit more careful and holistic in our approach as clinicians, whether that's at a primary care or even, well, less so on a specialty level because there's probably a specific focus, but at a primary care level, being able to identify whether patients may really benefit from multimodal therapies for separate things, which ultimately could reverse and manage all these things. So it'd be interesting to see whether managing obstructive sleep apnea early on could actually mean that testosterone levels don't decline as rapidly as we start to see. And there is an interesting look at kind of average levels of testosterone for men in the 2020s versus what they were decades back, and it has declined. I don't know the exact now off the top of my head, unfortunately, but it's very interesting. Now, why is that? Is that, again, as I've alluded to, society has changed how we live, what we put in our bodies, ultra-processed foods, possibilities of kind of toxins and microplastics and other things like that. And again, stuff for another discussion, which I would be delighted to have with you. But I think my key take-home message is awareness. Clinicians at least be more curious, ask those questions, engage in these discussions, be open, but also to listen to patients as well. And I think for patients, just be aware of these symptoms. If anyone is listening, of course, none of this is personalized medical advice, but we would hope that you would, if there is anything that you listen to that you felt might affect you or someone that you know, that you'd encourage them to at least seek some medical attention. namely main in the first instance with a GP. And I think really having that kind of frank discussion and self-education as well is really key.
Yeah, absolutely. Yeah, I think that's very, very wise advice. Hopefully we can have this conversation again in a year's time, 2 years time, and we'll be able to reflect on how things have got much better in the last 12 months and all of the kind of exciting things that have happened in our, well, I was going to say respective spaces, but perhaps collaborative spaces is a better term.
Absolutely. Well, Tom, it's been an absolute pleasure. I will bid you farewell.
Lovely to see you. Thank you very much. Chat soon.
Cheers, Tom.